Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on today's video. On today's video, we're in session number 2 of our new series entitled X-rays and Medical Research in the Qualified Medical Evaluation. And in our last session, we talked about the necessity of ordering diagnostic X-rays in almost every single case. Certainly chapters 15, 16, and 17 of the AMA guides, which deal with examinees with spine injuries and upper and lower extremity injuries. The AMA guides require X-rays for the assessment of many impairments of these body parts. So many doctors do not order the required X-ray studies, and they're failing to assess their examinee for the presence or the absence of these impairments. So in our last session, I encouraged you to adopt the practice of ordering diagnostic X-rays in every single case, and there is no valid reason at all whatsoever for failing to order diagnostic X-rays. So with that point established, we then spent a few moments talking about medical research, and it is quite apparent if you take a look at the DWC's new proposed changes to the complexity factors, which I'll admit are not yet adopted into law. But if you look at the languaging and the wording of the new proposals promulgated by the Division of Workers' Compensation, it's clear that the Division of Workers' Compensation favors reports that incorporate medical research within the content and the conclusions of the report. So many doctors do not incorporate their findings from medical research within the conclusions of their report. And I encourage you to start thinking about how you can use medical research to support your opinions and conclusions and to help resolve disputed issues. And in later sessions, I'm going to show you exactly how to formulate and format your findings of your medical research within the body of the report. But for now, I just want you to get it into your mind, two things: to order necessary and required diagnostic X-rays on every single case, and number 2, use the diagnostic X-rays and specifically abnormal findings on the diagnostic X-rays to conduct medical research on the significance of those findings as those findings relate to your examinee's particular circumstance. Now, in the remainder of our sessions in this series, I'm going to share with you 5 different examples of how X-ray studies have revealed significant and relevant clinical findings and how those findings required medical research in order to determine the significance of those findings on the examinee's situation. And I'm going to share with you exactly how the medical research was formatted in the body of the report and how the medical research was pivotal and necessary in arriving at opinions and conclusions that qualified as substantial medical evidence. So you're going to find this to be a fascinating discussion. And with that is our introduction today. Let's begin with today's material. Okay, so throughout the remainder of this program, here's a couple of the conditions that we're going to discuss. We're going to talk about X-ray findings which depicted a spinal anomaly known as a Ponticulus Posticus. And I'm going to share with you how this pre-existing condition factored into the examinee's injury, how it factored into the examinee's permanent impairment rating, and how it factored into the apportionment determination for that particular examinee. Then I have a couple of upper extremity cases to share with you, both of which involve carpal instability. And carpal instability in Chapter 16 is a fascinating concept. And I've done many recordings on carpal instability. And the X-ray measurements for the assessment of carpal instability, in my opinion, are fascinating. So I have 2 cases to share with you, one of which involves an otherwise normal wrist, but which depicts findings for carpal instability. And then the second case is also a carpal instability case, but diagnostic X-ray studies of the wrist also depicted a pre-existing condition of an anomalous development of the ulna bone known as negative ulnar variance. Negative ulnar variance. And I'll share with you how this finding of this pre-existing condition factored in to the important opinions and conclusions of that particular report as well. And then I have a lower extremity case for you, which involved patellofemoral pain and the assessment of patellofemoral arthritis as required in Chapter 17 of the AMA guides. Well, interestingly, the X-ray studies of the knee demonstrated trochlear dysplasia, which is an anomalous development, maldevelopment of the femoral trochlea, the groove through which the patella slides up and down. So this condition predisposes the patella to subluxation, to dislocation, and to patellofemoral arthralgia. So I'll share with you how this condition, this X-ray finding, factored into the important opinions and conclusions of that case. And then finally, I have a fascinating case for you which involved a lower back injury, wherein diagnostic X-ray studies of the lumbar spine, which are required in Chapter 15 for the assessment of loss of motion segment integrity. Remember, loss of motion segment integrity is one of the spinal impairments. So in every single spinal case, when your examinee is permanent and stationary, the guides require that we assess for the presence or the absence of loss of motion segment integrity in our examinee. And so in the process of assessing the examinee for loss of motion segment integrity, the diagnostic X-rays depicted pre-existing kidney stones, which are a known cause of lower back pain, similar to that back pain which was reported by the examinee. So I'll share with you how the findings of kidney stones impacted the opinions and conclusions of that particular report. And the purpose of sharing these cases with you is to reinforce two concepts. Number one, that diagnostic X-rays are required in every single case of injury to the spine, to the upper extremity, and to the lower extremity. And then number two, many times in the course of ordering routine diagnostic X-rays for the assessment of impairments, as required in Chapter 15, 16, and 17 of the guides, in the process of assessing for the impairments, you run across conditions, pre-existing conditions, that may or may not impact your final opinions and conclusions. And in these 5 examples that I want to share with you, each of these X-ray findings impacted in some way or another the opinions and conclusions of the report, and those opinions and conclusions in the report could only be arrived at through properly conducted medical research. So it's the medical research that lends substantial medical evidence to the opinions and conclusions in each of these reports, and I'll share with you exactly the process involved and the medical decision making involved in incorporating the medical research into the final opinions and conclusions. Okay, so let's begin today's session with a discussion of the spinal anomalies, and today's case, which involves a Ponticulus Posticus of the C1 vertebra of the spine. Okay, so let's talk about the spine. And imagine this, you have a case that you're working on, and you have decided to go ahead and order flexion and extension studies and the routine other views required of the spinal series that you're interested in. And you come up with some of these following findings on your X-ray images. Some of the anomalous conditions that can show up include platybasia, basilar invagination, occipitalization of atlas, and this is just a brief list, os odontoideum, We can sometimes occasionally see examinees who have a hemivertebra, examinees who have Klippel-Feil syndrome or a Sprengel's deformity, examinees who sometimes have a cervical rib. You'd be surprised how often you find cervical ribs in symptomatic examinees. Another condition that shows up occasionally on X-ray studies is DISH, diffuse idiopathic skeletal hyperostosis. So just to start quickening your thinking, imagine if you have an examinee with a cervical spine injury, and you're now assessing the examinee for loss of motion segment integrity of the cervical spine. How could a pre-existing condition such as a hemivertebra affect the individual intersegmental spinal motion of each of the spinal segments? It could affect the intersegmental motion, correct? What if you had an examinee that has an occipitalization of the atlas? Could that affect the examinee's range of motion? Say you're assessing the examinee and you're providing for permanent impairment rating under the range of motion method for the cervical spine. Could a condition such as occipitalization explain a loss of range of motion of the cervical spine? Of course it could. So in assessing your examinee for impairments in chapters 15 in this case, but also in chapters 16 and 17, in assessing for the impairments, we frequently find pre-existing conditions that impact the impairments and require medical research, not only to understand for ourselves the significance of the X-ray findings upon the examinee's circumstance, but also in some cases in order to help us explain to the reader of the report what's going on with the particular examinee. So in today's discussion, we're going to talk about a specific case of Ponticulus Posticus, and I'll share with you how the medical research factored in to the opinions and conclusions of that report. Okay, so here's a few conditions of the cervical spine. Let's talk about some other sections of the spine as well. So in the thoracic and lumbar spine, sometimes diagnostic x-rays reveal vertebral body anomalies, such as block vertebra, such as hemivertebra, such as Schmorl's nodes, such as a limbus bone. Imagine you received a report from the medical radiologist that described a block vertebra or Schmorl's nodes. Many times it's these diagnostic study findings that will springboard into medical research to investigate the significance of those findings on the examinee's impairment. Okay? In the thoracic and lumbar spine, other anomalous conditions impact other parts of the vertebra, such as the vertebral arch. So for example, we can have agenesis of a pedicle. We can have a spina bifida occulta. Could a spina bifida occulta be a source of lower back pain in an examinee? Of course it could. Of course it could. Imagine providing a permanent impairment rating for an examinee for a lower back condition when the examinee has a pre-existing condition of a spina bifida occulta. Could that impact the apportionment determination? Is it possible that a spina bifida occulta could affect the motion segment integrity of the spinal motion segment involved with the spina bifida occulta? Of course it could. So this is, I simply go through these examples to reinforce to you over and over and over again that diagnostic studies are required in every single spine evaluation. Okay? What about transitional vertebra? Could a lumbosacral transitional vertebra impact the motion segment integrity of the L5 and S1 spinal segment? Of course it could. If your examinee has a transitional vertebra, you need to know that so that you can provide accurate opinions and conclusions on impairment and accurate opinions and conclusions on apportionment as well. Also on spinal x-rays, we sometimes occasionally see anomalies of the ribs. We sometimes occasionally see anomalies of the sternum. So this is by no means an exhaustive list. This is just merely to highlight a few common spinal conditions that frequently show up Paradoxically, they show up when we take the time necessary to order the diagnostic studies that are required for our case. And then also, we're going to talk in this program about some upper extremity anomalies and also some lower extremity anomalies, and we'll get into those in our subsequent sessions. Okay, so let's talk about it. We're talking now about a cervical spine injury case wherein diagnostic studies revealed the presence of a pre-existing anomalous condition known as a Ponticulus posticus. Ponticulus posticus. And a Ponticulus posticus is an anomalous development of the C1 vertebra of the spine that involves this calcification here and this formation of a bony ring here, which is anomalous. This calcification is ordinarily not present, does not exist there, and it has significance as relates to this case because this case involved an examinee who had an auto accident. They were involved with a hyperflexion, hyperextension injury to the neck, and subsequent headaches, both in the form of muscle tension or muscle contraction type headaches, and also occasional migrainous headaches. So let's follow the flow of how the diagnostic studies led into medical research, which led to the opinions and conclusions of the report. Okay, so once the X-ray studies were completed on this examinee, the X-ray studies were accompanied by a report from the medical radiologist. And here is the report of findings of the X-ray studies from the medical radiologist. Medical radiologist stated that there was no fracture or dislocation evident, that there was no instability noted on flexion and extension views, and that the bones and soft tissues appeared normal. So the medical radiologist is describing these studies as normal. He stated that the bony alignment in the neutral position is relatively straight and may reflect evidence of muscle spasm. So here the medical radiologist does provide one finding, and that is a straightening of the normal cervical lordosis, which, by the way, is radiographic evidence of muscle guarding. He describes it here in the form of muscle spasm. For our purposes in permanent impairment evaluations according to the AMA guides, this is a radiographic finding for muscle guarding. Muscle guarding, deep guarding of the paraspinal muscles can straighten the cervical lordosis. So the medical radiologist did provide that finding, but that was the extent of the findings on this particular series of X-rays. Well, when I reviewed the studies myself, as a chiropractor, I'm familiar with spinal anomaly conditions, and I instantly zeroed in on the Ponticulus posticus. My eyeballs just naturally went to the Ponticulus posticus as an anomalous finding in the cervical spine. Well, either the medical radiologist failed to identify the Ponticulus posticus, or perhaps the medical radiologist, who has a large scope of practice beyond simply looking at X-rays all day, particularly spinal X-rays, perhaps the medical radiologist is not familiar or has forgotten about this condition. In any event, the medical radiologist neglected to identify this condition on the X-ray studies. So I called up the medical radiologist and asked him if, in his opinion, the examinee had a Ponticulus posticus of the C1 vertebra. And the medical radiologist did agree, and he provided this following addendum. And this addendum came after the initial report. So sometimes you'll have to do this. This is a principle. If you have significant findings on the diagnostic studies, it's always a good idea to call the medical radiologist and get on the same page with the medical radiologist and have the medical radiologist provide either an addendum or a statement or in some way document the finding that is of concern to you so that you can have it in the medical record that the finding has been identified. So the medical radiologist provided an addendum that stated there is subtle, partial ossification of the articularis posticus, best appreciated on the lateral flexion view. Now, this addendum, while it satisfies the need for the purposes of the report, indicated to me that perhaps the medical radiologist was not familiar with the condition of Ponticulus posticus, because he referred to it as articularis posticus, which is not one of the synonyms for this particular condition. And he also described it as subtle and partial. And in fact, the finding was not subtle and the finding was not partial. It was a profound finding and it was a complete ossification. But in this way, the medical radiologist perhaps sort of hedged his bets and suggested that perhaps this was such a subtle finding that he was unable to identify it on first glance, on his first reading of the X-ray images. In any event, we were able to get the medical radiologist to provide the necessary addendum. So once this condition was identified on the X-ray studies, medical research became necessary for a couple of reasons. Number one, to understand the significance of this finding, this Ponticulus posticus, upon the examinee's condition. Okay, that medical research was necessary in order for that. And then also to provide some education and some teaching to the reader of the report as to what this condition is and how this condition is going to impact the examinee as far as the opinions and conclusions of the report. And in my opinion, the presence of this Ponticulus posticus was pivotal in arriving at permanent impairment and apportionment determinations for this examinee. So medical research was necessary, and the first source for medical research was a textbook from Yoakum and Rowe, which is a radiology textbook. And in chapter 2 of that textbook, describing congenital anomalies in normal skeletal variants, we get some description of the Ponticulus posticus and the significance of the Ponticulus posticus. So let's review this medical research. Well, Ponticulus posticus has several synonyms. It's known as a pons posticus, a Ponticulus posticus, an arcuate foramen. It's also known in the literature as a Kimmerle's anomaly, and also as a retroarticular vertebral artery ring. And what this condition is, which is depicted right here in this bony ring calcification, this is situated between the anterior tubercle of the atlas here, the posterior tubercle of the atlas here, the lateral masses of the atlas is here, and this is the posterior arch of the atlas. So this is a calcification between the lateral mass and the posterior arch of the atlas, which forms this bony ring referred to as the arcuate foramen. So a posterior ponticle, and here in this description of the medical research, we're educating both ourselves and also the reader of the report as to this condition. A posterior ponticle of the atlas is ossification or calcification of the oblique portion of the atlanto-occipital membrane that bridges the posterior lateral mass and the posterior arch. So here's the posterior lateral mass, here's the posterior arch. It forms the peripheral border of the arcuate foramen, which transmits some important neurovascular structures, including the vertebral artery and the vertebral veins, and also the first C1 cervical nerve, and also some sympathetic nerves that are involved in regulating the tone of the vascular structures in and around this region. So could these structures be important in the clinical syndrome of headaches, both muscle contraction headaches and migraine type headaches? Of course they could. So it's important to lay the foundation for the opinions and conclusions later on in the body of the report with some education, both for ourselves as the evaluator, but also for the reader of the report. And it's also important to provide it to the reader of the report in language that they can understand. And this medical research here, at least as far as it goes, does a good job of doing that. Okay, and our description of this condition, at least according to the medical research, continues. And here we tell the reader that this condition is usually bilateral. And even though it's bilateral, it's typically asymmetric, meaning the calcification is not symmetric side to side, but there is some asymmetry in comparing the calcification on one side of the atlas with the other side. Partial ossification is found in up to 35% of the population, and the complete ring-like form has been found in up to 15% of the white population. We tell the reader of the report that it's not present at birth and generally first appears during puberty as a secondary ossification center, and it increases in prevalence with age. So here is an image which depicts the Ponticulus Posticus, and it shows the calcification ring of the posterior ponticle right here with the formation of the arcuate foramen right in through here. Now this is important because this bony roof, this calcification here, constrains the neurovascular structures in this region, including the first cervical nerve, the C1 cervical nerve. Now let me ask you, in Chapter 15 of the AMA Guides, when we consider whether the examinee has radiculopathy or not, we typically think of radiculopathy as involving the C5 through the T1 nerve roots. But if we have an examinee here who has an entrapment of the C1 nerve root, and some inflammatory syndrome of the C1 nerve root due to constraint through the arcuate foramen here, would that be a form of an atypical radiculopathy? Is this an important finding in providing for perhaps an alternative impairment rating in this examinee? Of course it is. And this diagram here depicts the tortuous route of the vertebral artery, which first goes through the vertebral foramen over here on the lateral aspect of the atlas. This is the transverse process right here. And the vertebral artery is ordinarily tortuous and twisted here anyway. But now in this case, with the presence of a Ponticulus Posticus, the vertebral artery is further constrained through the arcuate foramen here and can be a source of migrainous type headaches. So this medical research is necessary in determining the examinee's condition and in providing appropriate and accurate opinions and conclusions in the body of the report. And this medical research is necessary both for the evaluator and also for the reader of the report. Okay, so let's talk about the impact of this condition on this particular examinee. In this case, the case involved a 27-year-old female. She was involved in a rear impact, hyperextension, hyperflexion injury to her neck. Her car was stopped on the off-ramp of a freeway when she was rear-ended by an inattentive driver. So she simultaneously had a workers' compensation and also a personal injury case. When I first evaluated her, she was reporting to me an occasional frequency, a very occasional frequency of neck pain and headaches, with a even lesser frequent occurrence of migraine headaches. So to state that differently, she reported to me that she was having occasional, perhaps once a week, suboccipital type of muscle contraction headaches, and she had had two episodes of what she described as migrainous type headaches with photophobia, and phonophobia and throbbing, terrible pain in her head. And when I evaluated her, I determined that she was not permanent and stationary, and I advised that she continue medical care, at least for observation, until the 12-month anniversary of the date of injury. And at the time, I considered the majority of her symptoms to be kind of the typical whiplash syndrome with perhaps a component of mild traumatic brain injury and post-concussion type of symptoms. And certainly she probably did have both components of both of those syndromes active and causing her these headaches and this occasional neck pain. But when I found the X-ray finding of the Ponticulus Posticus, it caused me to modify my opinions and conclusions somewhat. So by the time I saw her back, she had passed the 12-month anniversary of the date of injury. And even though I provided for ongoing medical treatment for her, really she had not received any medical treatment except for one urgent care visit for migraine headaches. So she continued to experience occasional frequency of neck pain, suboccipital headaches, and a much lesser frequency of migraine headaches. In the meantime, between the two evaluations, she had been prescribed a couple of different medications. She had been prescribed Topamax for suboccipital headaches, and she took the Topamax medication when she felt the onset of a suboccipital type of headache coming on. And then for the migraine type headaches, she was prescribed sumatriptyline medication, and she stated that both of those medications were quite helpful and significantly reduced the severity of both the suboccipital and the migraine type headaches when they occurred, but she was concerned that she was still experiencing some frequency of these headaches, and especially the migraine headaches were particularly devastating to her, causing her to take a day or two off of work, causing her to have to retreat to a dark room, causing her to have to wear dark glasses in order to avoid exposure to bright lights. And all of the symptoms that we typically associate with migraine headaches, she was continuing to experience these symptoms for the first time in her life following the industrial injury. So when I examined her on the second meeting, her cervical spine examination was mostly normal. And here is the impressions of the examination that are exactly extracted from the report. The cervical spine examination was normal for range of motion and upper extremity neurologic function. So in other words, the examination was negative for typical radiculopathy that we would associate with the C5 through T1 nerve roots. Similar to the previous examination, the one significant finding on physical examination was pain at the left suboccipital region with foraminal compression testing. This is a physical examination finding for atypical cervical radiculopathy, and here I let the reader of the report know that this finding contributes to permanent impairment. So the reader gets his first indication that physical examination findings are going to result in an opinion on permanent impairment. And here I refer the reader of the report to the permanent impairment section in the report below. Now, when I provided my own report of findings on the diagnostic studies, my report of findings differed slightly from the findings as described by the medical radiologist. And this is a principle. When you order diagnostic studies for your examinee, the report that you receive from the medical radiologist is not the final opinion on the findings. The final opinion on the findings rests with you, the evaluator. So always, always, always Review the diagnostic studies yourself, and always, always, always provide your own written report of findings directly below the findings that were provided by the medical radiologist. So here were my findings as described in the diagnostic study section of the report. Stated, there is straightening of the normal cervical lordosis, and that was exactly a similar finding to what the medical radiologist described. This is due to flexion subluxation soft tissue lesion of C5, C6, and C7 vertebrae. And I use this language because permanent impairments in Chapter 15 are described as soft tissue lesions. This is found in Table 15, I believe it's 15-7 of the AMA guides, which we'll review in just a couple minutes. I stated that disc spaces are preserved throughout, and that's what we would expect in a 27-year-old female with no prior history. There are no findings for degenerative change of the cervical spine. There is a partial or an incomplete calcification of the posterior atlanto-occipital membrane. This is an anomaly of the C1 vertebra, and here I introduce the finding of the posterior ponticle. I refer now back to the medical radiologist, and I say that Breslaw, MD, referred to this as a partial ossification of the articularis posticus. This is most commonly referred to as Ponticulus posticus. See medical research below regarding this finding. And here we introduce the finding, we introduce the anomalous finding of the posterior ponticle, and we refer the reader of the report to the medical research, also within the same section of the report. This is also within the diagnostic study section of the report. We refer the reader to the medical research section of the report so that the reader of the report can find out, what the heck does this mean? What is this condition? What is this posterior ponticle? And what does this have to do, if at all, if anything, what does this have to do with the particular examinee? And we'll get into that right now. So before we explain to the reader through our medical research what the significance of this Ponticulus posticus is, we go ahead and we do what we're supposed to do, and we analyze the cervical spine x-rays for loss of motion segment integrity as required under Chapter 15 of the AMA guides. And so here is the analysis of motion segment integrity. And without going through all of the math involved with assessing each individual spinal segment, I'll just let you know that I found normal motion at the C1, C2 segment, found increased motion at 16 degrees at C2, C3, found normal motion at C3, C4, increased motion at 20 degrees at C4, C5, and I found decreased motion at 11 degrees and 13 degrees at C5, C6, and C6, C7. Remember, with analyzing these angular motion measurements, the AMA guides tell us that there's about 10 degrees of angular motion at C2, C3. So here's at C2, C3. We expect to see about 10 degrees of angular motion here, but this examinee is giving us 16 degrees. And then angular motion increases gradually to about 20 degrees at C5, C6, and C6, C7. So we probably pick up about +2 to +3 degrees with each spinal segment that we progress downwards towards C6, C7. So if we're ordinarily going to get 10 here at C2, C3, C3, C4 should give us about 12 to 13 to 14, and we're getting 12 degrees. That's about normal. The next segment should give us about 14 to 15, and we're getting here 20 degrees, which is increased. The next segment should give us about 16 to 18. We're only getting 11, so that's decreased. And C6, C7 should give us about 18 or 20, and we're only getting 13 degrees, so that's decreased. So we do our analysis of motion segment integrity, as we're required to do under Chapter 15 of the AMA guides, and we'll see how this factors in to the impairment determination in just a few minutes. But before we even get into the impairment section, we go into the medical research section and explain to the reader what is this condition and what does this condition have to do with the examinee. So by going online onto an online journal, the Journal of Clinical Diagnosis Research, you find an article in the dental literature. In other words, this condition frequently shows up on dental x-rays. This study was entitled Ponticulus Posticus of the posterior arch of the atlas, a prevalence analysis in symptomatic and asymptomatic dental patients in the country of Gulbarga. So here we explain to the reader of the report that a study was carried out to substantiate this finding, this Kimberley's anomaly or Ponticulus posticus, as a possible cause of chronic tension type headaches, as in the case of my particular examinee, who we'll call Miss Lucero. So here we relate the medical research to the particular examinee. So this is added in. This is added in by the author of the report, which is you. And also neurosensory type hearing loss in a patient with a known history of headaches and accompanied unilateral hearing loss. Well, our particular examinee did not have hearing loss, but the examinee does complain of chronic tension type headaches. The headaches demonstrated the characteristics of the chronic tension type headaches. The hearing investigation concluding the hearing loss to be of the neurosensory type, whereas the imaging examination revealed the existence of a partial osseous bridge, that is an incomplete arcuate foramen of the upper surface of the atlas. Both the clinical and the radiologic findings of this case were indicative of a possible connection between the Ponticulus posticus and the manifestation of chronic tension type headaches and also hearing loss. However, in contradiction to the above mentioned study in which they found symptoms only in patients with partial or incomplete forms of Ponticulus posticus, in our study we found that patients with both the forms, meaning both partial and complete calcification, both forms had symptoms of tension type headaches and migraine in the age group of 16 to 45 years, which is similar to our examinee at 27 years of age. In our symptomatic group, out of 42 patients who had partial form of Ponticulus posticus, 25 were females, 17 were males, while among 31 patients with the complete form of Ponticulus posticus, 15 were males and 16 were females, with females showing a higher rate of symptoms than the males. And this was the exact type of finding in the medical research that was going to provide the foundation for the opinions and conclusions in the impairment and apportionment sections of the report. So I concluded the impressions of the diagnostic studies section by giving the reader of the report the significant findings of the diagnostic studies. Number one, there is flexion, subluxation, soft tissue lesion at C5, C6, and C7 vertebra. This causes straightening of the normal cervical lordosis, and this is a radiographic finding for muscle guarding. Muscle guarding contributes to loss of motion segment integrity at C2, C3, C4, C5, C5, C6, and C6, C7, where the upper two spinal segments show increased intersegmental motion and the lower two spinal segments show decreased intersegmental motion. And you'll notice that in providing this type of a summary of the diagnostic study findings, we're providing a summary that we can relate to later on in the report in the impairment section of the report. So it's these findings that lead the foundation for the impairment opinion later on. We also inform the reader that pre-existing partial calcification of the posterior atlanto-occipital membrane, known as a Ponticulus posticus, contributes to Miss Lucero's symptoms of chronic tension type headaches and migraines. And here we refer the reader of the report to apportionment section of the report, wherein this information is going to be pivotal in the apportionment determination. So now let's bring this all together and let's go through the impairment and apportionment opinions in this case. So first I provided the reader of the report with an impairment opinion under the strict application of the AMA guides using the range of motion method. Remember that the range of motion method involves three components. It involves specific spine disorders, it involves abnormal motion or loss of spinal range of motion, and then it involves neurologic deficits. So with regards to the specific spine disorder, the examinee's condition is accurately described in Table 15.7 as soft tissue lesion, and that's the same type of language that we use to refer to the straightening of the cervical lordosis. In this case, this soft tissue lesion is unoperated on with medically documented injury, pain, and rigidity associated with none to minimal degenerative changes on structural tests. This qualifies for 5% whole person impairment. Number 2, under abnormal motion, Ms. Lucero does not qualify due to loss of range of motion because her ranges of motion exceeds the normal ranges of motion as described by the AMA guides, even though we have findings for changes in intersegmental spinal ranges of motion on our radiographic studies. This normal range of motion on physical exam does not qualify for permanent impairment under the strict application of the AMA guides. However, I provide an alternative impairment opinion below. For neurologic deficits, in Chapter 15 of the AMA guides, tables 15-17 related to motor nerve root function, and 15-18 referring to sensory nerve root function. These tables provide for permanent impairment of the cervical spine nerve roots C5 through T1. This does not exactly describe Ms. Lucero because the nerve roots involved in causing her headache pain is the C1 nerve root. C1 nerve root. The AMA guides do not provide an impairment rating for this atypical form of cervical radiculopathy. However, I provide an alternative impairment opinion below. And then under the strict application of the AMA guides, she qualifies only for 5% whole person impairment. Well, in my opinion, Ms. Lucero's final permanent impairment rating is most accurately described under an alternative impairment rating method because the strict application of the AMA guides does not exactly describe her condition and does not exactly describe her impairment. So under the strict application of the AMA guides, remember that we said she qualifies only for 5% whole person impairment. Now remember that when we provide an alternative impairment rating, we have to follow an exact procedure. It's a 4-step procedure described in the Alvarez and Guzman cases, wherein we provide first the strict impairment rating, and then we explain to the reader of the report why the strict impairment rating is not accurate, and that's step number 2. And then step number 3, we provide an alternative impairment rating, and then we provide an explanation to the reader of the report why the alternative impairment rating is the most accurate description of the examinee's impairment. So here we do step number 1 and we reiterate the permanent impairment rating under the strict application of the guides. Step number 2, we tell the reader of the report why the strict rating is not accurate. And here I explain that in my opinion and within reasonable medical probability, the strict impairment rating is not accurate because number 1, it does not capture the atypical radiculopathy responsible for Ms. Lucero's headache complaints, and that's because the AMA guides discuss only radiculopathy for nerve roots C5 through T1, and Ms. Lucero has radiculopathy of the C1 nerve root. Thus, Ms. Lucero presents with an unlisted condition not discussed by the AMA guides. And number 2, it does not address the excess motion and loss of function of the individual spinal segments of her neck, which is discovered on flexion extension radiographs, and we refer the reader of the report to the diagnostic studies above, wherein those findings are elaborated on. Here we do step number 3, and we provide the reader of the report the alternative impairment rating. In my opinion, Ms. Lucero qualifies for permanent impairment most accurately described under cervical DRE category 4. According to the AMA guides, category 4 involves alteration of motion segment integrity or bilateral or multi-level radiculopathy. Although the DRE cervical category 4 requires only one of these findings, meaning alteration of motion segment integrity or radiculopathy, in my opinion, Ms. Lucero has both of these findings. She has multi-level loss of motion segment integrity, and she has bilateral radiculopathy of the C1 nerve root, which is causing her occipital neuralgia. These are the after effects of the whiplash injury that Ms. Lucero suffered on 12/1/17. According to Table 15.5, this qualifies for 25 to 28% whole person impairment. In my opinion, she qualifies for the higher value in the range because she has 2 clinical findings rather than 1 clinical finding required under the DRE cervical category 4. So this is step number 3, which is to provide an alternative impairment rating. And then step number 4 is to explain to the reader of the report why the alternative impairment rating is the most accurate rating within the 4 corners of the AMA guides. And that explanation is as follows. Number 1, loss of motion segment integrity. The analysis of motion segment integrity, see diagnostic studies above, reveals that Ms. Lucero's neck was badly sprained in the injury. This creates a mixed pattern of abnormal spinal intersegmental movement patterns, with some vertebrae demonstrating increased intersegmental motion and others demonstrating decreased intersegmental motion. This represents a significant loss of function of the spine, which is accurately addressed by the DRE category 4 rating. Radiculopathy. Ms. Lucero has non-verifiable radiculopathy of the C1 nerve root. This is not discussed in the AMA guides, but is clinically relevant as the source of frequent non-migrainous headaches that Ms. Lucero reports. This is a bona fide condition not addressed by the AMA guides. By analogy to other cervical spine nerve roots, such as C5 through T1, which are addressed and discussed in the AMA guides, it is my opinion that Ms. Lucero qualifies for similar impairment to radiculopathy of any of the other C5 through T1 nerve roots. Finally, because Ms. Lucero has physical examination and diagnostic study findings for both number 1, loss of motion segment integrity and non-verifiable radiculopathy, it's my opinion that she qualifies for the higher, which is 28%, whole person impairment value. So that was the impairment opinion. We provided an impairment rating using an alternative method by analogy to DRE cervical category 4 for loss of motion segment integrity and radiculopathy, even though in this case the radiculopathy was atypical. Now let's go on to the apportionment determination. And remember that we found a pre-existing condition known as the Ponticulus Posticus. And let's see how the Ponticulus Posticus, if at all, impacts the apportionment determination. So here is the apportionment determination. In my opinion, and within reasonable medical probability, 100% of the permanent impairment of 28% whole person is due to the industrial injury, and 0% is due to other factors. Wow, 100, 0, 100, 0. And here in the report, We support that opinion by providing to the reader our reasons for this conclusion. And my reason that 100% of the impairment is due to the industrial injury includes the following reasons. Number one has to do with the mechanism of injury. With the industrial injury, Miss Lucero suffered a severe mechanism of injury when her stopped vehicle was rear-ended by another vehicle with sufficient speed and force of impact to drive her vehicle into the rear of another vehicle to her front. This resulted in the classic whiplash, cervical hyperflexion hyperextension, injury to her neck. To the frail and spindly neck of Miss Lucero at 5 feet 1 inch and an unmuscular 140 pounds, this was a severe injury. So here I give the reader of the report some details that suggest that indeed this injury to this particular examinee was in fact a severe mechanism of injury. And as we know from the Escobedo case, the more severe the mechanism of injury, the higher the percentage of apportionment is toward the industrial injury, and the lesser is the percentage of impairment due towards other factors. So here we provide for 100% impairment due to the industrial injury, in part due to a severe mechanism of injury. Number two, Miss Lucero had immediate medical care. This injury, which I classify as severe, required same-day medical care. In fact, as soon as the details of the accident, such as getting her car towed off the freeway and arranging for one of her parents to pick her up from the accident scene, were handled, Miss Lucero presented for medical care. Her condition at the time was described by Methodist Hospital, and here we refer the reader of the report to the citation above in the review of records. Her condition was described as history. Patient is a 25-year-old female with no significant medical history who presents to the ED with complaints of head, left eye, and neck pain after a motor vehicle accident that occurred 3 hours ago. So again, this is indicating to the reader that the injury was severe. It was so severe that she required immediate medical care. She didn't wait till the next day. She didn't wait a week. She reported for medical care same day. The third reason that 100% of the impairment is due to the industrial injury has to do with an aggravation of a pre-existing condition. And here's where the medical research and the whole diagnostic study findings of Ponticulus Posticus comes to bear in the conclusion of the report. I tell the reader that the injury aggravated a pre-existing asymptomatic condition of the cervical spine. This condition is a spinal anomaly referred to in the literature as Ponticulus Posticus, and we refer the reader of the report to that section of the medical research above. Prior to the industrial injury, this condition was asymptomatic, and Miss Lucero had none of her current symptoms. She had no complaints of neck pain. She had no complaints of tension headache. She had no symptoms associated with post-concussion syndrome. The industrial injury lit up and rendered symptomatic this pre-existing condition. So the whole point of the medical research was that the industrial injury aggravated a pre-existing asymptomatic condition of the spine. That condition of the spine is known as a Ponticulus Posticus. And then we provide finally the reader of the report with an opinion as to why 0% of the permanent impairment is due to the industrial injury, is due to other factors, by stating that although I acknowledge that Miss Lucero had a pre-existing condition of the cervical spine, prior to the industrial injury of 12/1/17, that condition was entirely asymptomatic, and within reasonable medical probability it would continue to be asymptomatic through the date of injury and even through the date of this evaluation. In other words, absent the industrial injury of 12/1/17, Miss Lucero would not have impairment or disability of the cervical spine due to the pre-existing condition. Therefore, there are no other factors to consider. And boom, in this way, the examinee was able to get an appropriate level of permanent impairment and an appropriate level of apportionment for an industrial injury that aggravated a pre-existing condition. And this is a principle. Many examinees have pre-existing conditions, both symptomatic and asymptomatic, and the apportionment determination can be handled similarly in those cases, wherein if you believe that the examinee would continue to be asymptomatic absent the industrial injury, well then therefore 100% of the impairment is due to the industrial injury and 0% is due to other factors, because to opine that the examinee would have disability associated with a Ponticulus Posticus, that she would have headaches, that she would have neck pain, that she would have migraine type headaches at any point in time in the absence of the industrial injury would involve speculation and conjecture. And of course, we are prohibited from providing our opinions and conclusions based on speculation and conjecture. So in this way, the medical research was able to contribute to accurate opinions and conclusions to the benefit of this examinee. So doctors, I hope this helps you. This case beautifully exemplifies how the diagnostic studies and the medical research integrate perfectly to arrive at accurate opinions and conclusions for this examinee that can be arrived at accurately no other way. The diagnostic studies revealed the presence of a pre-existing condition. The diagnostic studies revealed the presence of a spinal impairment, which was the loss of motion segment integrity of multiple segments. And I was able to conclude through the medical research and the diagnostic study findings that the industrial injury aggravated a pre-existing, although asymptomatic, pre-existing condition, which now has been rendered symptomatic and which is causing the examinee symptoms and which is causing the examinee loss of function, which is the definition of impairment. So to review, the procedure involved with every one of these cases is roughly the same. Number one is order the necessary studies that are required by the AMA guides. In this case, we're talking about Chapter 15 with spine injuries. So with every single spine injury case, order the routine views for the cervical spine and also order the flexion and extension radiographs so that you can assess for loss of motion segment integrity. Number two, if there is a pre-existing condition, the X-ray studies allow you to discover the pre-existing condition. Once you discover the pre-existing condition, if the medical radiologist himself or herself has not described the condition in his or her report of findings, then enlist the medical radiologist to obtain the description of the condition necessary so that you can then have authority to proceed to do the necessary medical research. Then number four is to go ahead and do the necessary medical research so that you can understand the significance of the findings on the examinee's circumstances, and also so that you can provide language to the reader of the report to explain and educate to the reader of the report what's going on with the examinee. This serves to greatly educate the readers of the report as to what's going on with the examinee. And this can be done in no other way without the medical research. And then once you've done the medical research, you use the medical research to resolve disputed issues. Remember, medical research is to be used to resolve disputed issues. There's no need to conduct medical research if the medical research does not resolve a disputed issue. In this case, the issues under dispute was the extent and degree of permanent impairment and the degree of permanent impairment due to the industrial injury. So that was an impairment and apportionment dispute, and the medical research beautifully helped to resolve any dispute within reasonable medical probability that any party could have regarding the permanent impairment or regarding the apportionment. Would you agree? Those opinions and conclusions that I shared with you regarding the impairment and the apportionment are roughly irrefutable, and they're well supported by relevant facts found within the diagnostic study findings and supported by relevant facts from citations in the current medical and scientific literature, which we refer to in the body of our report as medical research. So doctors, I hope this helps you. I want to encourage you to obtain diagnostic studies on every single case and to perform medical research as necessary to resolve disputed issues. So today we talked about an example of a spinal injury case that involved a spinal anomaly. In our next session, we're going to talk about similar circumstances involving the upper extremity. So I want to thank you for taking the time to join me on today's video. Look forward to being with you on our very next video as well. And for now, I'm wishing you best of success in your career as a qualified medical evaluator.